It should be inherent to an echo study. So we'll talk about how to integrate 3D echo into the studies. And then we'll do that kind of quickly. We'll stop for questions if you have any. And then I'll actually jump into a protocol that we're developing for mitral valve clipping, which I think is sort of a nice example of how we do integration of 3D imaging. I see several hundred of you standing at the back. If you'd like to come up, there's a couple of seats at the front. For those that care about their attendance, there's a QR code here. I encourage you to click it, and then if that actually works, you can also evaluate me. I only take fives. It is a 5-point scale, just to be clear. All right, so I'll show that at the end for any latecomers, or at the halfway point at the end. You missed it. All right, so there are guidelines on how to do a 3D echo. ASE has one as well, but this is sort of the most comprehensive one. Just show it as a reference. This is sort of, when to use it, how to display. If there is standardization, this is basically where you'll find it. A couple of basics about the acquisition of 3D. There's different ways historically. Most of it we don't use anymore. There is the narrow angle, sort of shown here. It's sort of, if I can get my mouse to appear all the way over this screen. Oh, here it is. All right. So this narrow angle, 60 by 30, we don't use it very often. Occasionally it's a relatively high frame rate, so we'll look at something, but I'd say this is not a workhorse view. The 3D zoom is the one we use every day, and this is basically you create a small sub-volume. It's shown as 30 by 30. It can be almost any angle, but it's sort of pre-cropped, and I'll come back to that one. This is what we use all the time. And then the wide volume, we don't use this at all. In the TE world, you certainly can use this for transthoracic, and the application of transthoracic is basically LV volumes. This is an example of how we place sort of the narrow volume. This really, you have to think of the volume as always a triangle, but unlike CT or CMR, it's not isovoxel, where every dimension is the same. It's always derived from a pyramid. So the top is always smaller than the bottom on every echo, always. That's the physics of ultrasound. So it's not immediately comparable to a CT or CMR in terms of how you get a volume. And that also becomes relevant in the imaging because we have shadows and things from the top. So we're always still imaging from the top, even if it's a 3D. This is the sort of the workhorse view, the zoomed view, but zoom doesn't necessarily mean small. Sort of how we place it. In this view, There we go. Okay. All right. So that's how you would set a little volume on just the mitral valve and look at it that way. And this is a transthoracic example, but we do this. We'll show how we do that. But this sort of highlight the zoom view that we use a lot of. So zoom, really the application is, it's a small tomographic intent, so typically valves. Very often you get a very good mitral valve from a transesophageal, simply the orientation of the esophagus and the left atrium gets you a nice perpendicular view, so you tend to get a very, very nice mitral view. 70–80% of the time you get a nice aortic. Tricuspid, more challenging, again, because it's anterior, so more like 60–70% you get a decent 3D, and almost never on the pulmonic valve. And then multi-beat acquisition, really it's kind of a historic slide. We don't do multi-beat really anymore. Early days, single beat was such a low frame rate, you had no choice. 15 years ago when whether 3D echo became commercially available, the single beat volume flow rates or volume rates were so low that it was very stroboscopic. You couldn't be sure you had end systole. So we would often stitch together multiple beats. These days, single beat is so much better. We almost never veer out of single beat. So this is really a historic slide these days. But frame rate matters. And this is a little cartoon about you don't know what happens to this guy at a low frame rate. Maybe it ends well, maybe it doesn't. You don't know. You missed the frame. So this is important for end systole. Did you really get end systole or not? You don't know on a low frame rate. Is this thing wiggling independently or not? So you need frame rate a lot of the times. So obviously the story's not as great with a higher frame rate. So this is why frame rate matters. So how do we get frame rates up? Is you go the smallest sector you can, and typically it's width. Width is a big driver on frame rate. So this is how we set up a view, two orthogonal long axes. Typically mitral valve is a very nice, this is an example of the blue box of the pre-cropped volume. This is the tricky part. You get this volume, it's displayed to you like this, and then you have to manipulate it typically with the wheel. So you tip it forward to look down on it, and then historically you could either back rotate or somehow rotate to put the aortic valve at the top to give you a standard view. And that's kind of the challenge, is you get the volume blob, then you have to know what to do with it. We try to teach mastery of the trackball, and that the Z-rotate is a sign of weakness. But here's how you set it up. And we talk about this all the time. The key to a good volume view is you have to have the heart vertical, because basically you want to be perpendicular to the mitral valve. So you put the apex at 6 o'clock, and that's really where the work is. You got to work the TE probe so the apex isn't off to the side, the LV isn't angled. If you make it vertical and you make a horizontal LV, then you get a very nice mitral view. And then it's just three. The left box, you set the width and the height. The right box is going to be the same height always, and all you can do is adjust the width, and then you get a 3D, in this case showing a P3 flail. So that's how we set it up, and that's the work. As long as you've done that properly, you'll get a good 3D. You have to turn down the gain because you get blood mud. The brown stuff appears in the LA. You just turn down the gain until that's gone. And then we have different kinds of things. These are fun distractions these days. So we've got the classic 3D view, the coloration to give you depth perception. We've got these variable light sources at the bottom. We keep playing around. They look nice. You can move shadows around, and you can perhaps be helpful in a PVL to find a hole. But usually color Doppler is going to show you that anyway. I have yet to have a case where I understood something differently or better by the pink views. And that's really the point. But they're pretty, so we still show them once in a while. Examples of the valve imaging. So just you've seen a normal valve, and just to highlight what a very stenotic valve can look like. And you really see everything, commercial fusion, and we showed this case last week when we talked about MS. One of the tips on 3D is to not be fooled. Oh, this one's not playing. I don't know why. Okay, well, I think it'll still work. One of the problems is the color can be very overwhelming. You're looking down the gun barrel of the valve, and you just get this cloud of color. You can't tell where it is or how severe it is or what direction it's going in. So one of the first things you have to be comfortable doing is you turn up the filters. Okay, so this is a different case. Low wall filter, this is the default. You turn up the filter typically to 8 or 9, the max zone. And then you see, gets rid of all the other higher velocity stuff, but now you can actually identify in this previously repaired mitral valve where the leak is coming from. It's right down A2, P2. It's not everywhere, and that's part of the evaluation of could we perhaps do a mitral clip on this case. Okay, so I'll show you a case from actually just last week to sort of highlight how we're integrating 3D echo. So it's not a modality, and one of the messages is you don't ever do a 2D echo, then a 3D echo, and try to put them together. You really should be integrating as you go. Here's the view, here's the 2D, add a 3D when needed. That's what was supposed to be happening. So this is a case from last week. This was a bioprosthetic mitral valve. It was stenotic. There's the Doppler, mean gradient of 9. It's a cath lab case, so lots of people. The intent was to do a transseptal valve-in valve procedure. So take a sapien valve upside down and stick it inside this valve to get rid of the MS and hopefully not cause any paravalvular leak. So again, an example of how we integrate the stuff. So mid-esophageal view, add the color, do color compare, understand where the leak is, understand there's a completely frozen leaflet. Do a 3D en face routinely, looking down the gun barrel from the LA. You can see the valve is not opening. You also see some other details. See these little nodules all the way around? That tells you this was sewn in with single interrupted sutures, so not a running stitch. That has some implications. One is PVL. PVL tends to be where stitches are. And you also sort of learn your surgeon, if you work in the same place long enough, who does what. But this is a bioprosthetic valve sewn in with interrupted sutures all the way around and clearly becomes stenotic. As we guide things, we're using 3D all the time. So here's we getting comfortable with the trackball, sort of tipping angles a little bit. So now we have a transseptal, we have a wire, so we guided a transseptal across. You see shadows that get created, right? These aren't tears in the septum, this is just a shadow. Even though we're looking from the side, the image is created from the top down. So you don't always, the shadow isn't always your perspective, it's you have to understand the top of the pyramid is always where the probe is. So the shadows may not be where you expect them, but you have to sort of tip and remember what you've done. So here we have the shadow from above, that's the transseptal wire. And then just a moment later, we have a catheter delivered. The catheter is trying to be directed across the prosthetic valve, the stenosis. The fellow in this case is sort of probing with a little wire. He keeps missing it, and you give a little bit of advice. So you have to be a little more anterior, clock your catheter a little bit so you're aiming in the right spot. But you're giving very direct feedback based on the real-time guidance of these things. And again, you see a different shadow over here. So recognizing what the shadows are, they're not tears, they're just data voids. That's part of the effort. A couple of things just to point out technically. You see, there's a very modern probe. You're still only getting about 8 hertz. So it's a fairly big volume. We're trying to see a whole lot of the left atrium. It's wide. And when you make that choice to be a big volume, you get a relatively low frame rate. In this case, that's fine. Catheters aren't moving that fast. This frame rate is sufficient for what we need. So this is kind of a new thing. It's getting a lot of interest in the 3D space these days, is getting comfortable with MPR. MPR is multi-planar reformatting. So it basically means you take that same data set, and there's different button options, but what you're doing is you're choosing to display a 2D image derived from the 3D. So it's going to be a little less spatial resolution than an actual 2D, but it's much better than it used to be. So for a long time, we didn't use this very much. The probes were pretty good at this. We got comfortable with the resolution of the volume image in the bottom right, but a 2D derived from a 3D wasn't very impressive. But now it is. So there's been enough technical advancements in the probes and in the software. This is actually becoming a very useful thing. So what we're learning is, or what the trajectory of the comfortability in this is, you have to recognize what the boxes represent. It never projects well, but you can see there's a green box here, which is created by this green cut line. This is a red box created by this line. And then this is actually the blue box, which is created by this line. So the lines don't show up very well. They should be thicker. You should be able to dial them up for display purposes. You can't yet. But this is important. And then where this white line is basically the view down that creates the volume view on the bottom right. So you can move this up and down and change this volume. But this is a nice display. You can say, okay, I've got a blue line directly across the valve. I know what level it's at. Now I can look down at the stenotic valve and actually derive a planimetered area if I wanted to. If you don't know what depth you're at, you can't really do that. So this is where the advantage is now you can define the depth in 2 orthogonal planes, just like in any other volumetric image, CT, MRI, or anything. So it makes it more consistent in that mode. Same view, we're using this now to actually guide the procedure. So this is a balloon placed across the valve, balloon with a catheter. So this is actually a sapien valve that's going to be deployed. Sort of watching everything in real time. You can see the trajectory of, in the atria because you've defined everything. So this saves you going back and forth. You're not going from 2D to 3D to 2D to 3D. You just set it, you don't forget it, but you set it, you hold it, and you work in this view, as long as the quality is good, and this is a good quality one. You can quickly toggle on color when you want to. Now you have color from all the views, 2 orthogonal views. At the beginning, there was very little color. Now there's a tremendous amount of color. What's happened is because we've got a wire across. We've got a wire across the valve. Anesthesiologist saying the pressure's dumping is because you're holding the valve wide open. And you have to recognize that because interventional cardiologists get kind of busy doing their thing. They're doing exchanges, pressure's falling. The MR was only mild a minute ago, now it's severe. So casually you can interrupt valve function. So you have to sort of be aware of how fast you can evaluate that and just tell everybody, move your wire, you're holding the valve open. And then this bottom right is the deployment. So that's the sapien valve going in. And it's very controlled. You see the balloon go up, you see what you can evaluate depth, all in one view. So this NPR view, I'd say if you had to learn one thing about 3D echo this year, it's NPR. Because this is now the workhorse in tricuspid imaging and mitral imaging and all kinds of valve and valve imaging. Operators now want to see the NPR. Doesn't always look this good. There are times that the 2D is just okay, the 2D is just okay, the 3D is going to be just okay. It doesn't always look this good, but this was a particularly decent one and worthy of presentation. And this is an application of how we used it. So valve goes in, things look good, gradient is better, but on the fluoroscopy, the new valve, the sapien, still was kind of pinched a little bit. Didn't look like it was fully expanded, even though it was balloon expanded. So I said, okay, well, let's measure it after the first nominal deployment, so what the valve is supposed to be inflated to, and we wanted to get a diameter across the valve at a known exact depth, so that's why I use NPR. You know exactly what depth you're in the 2 orthogonal planes. You can get either an area if you want, but more importantly, 2 orthogonal diameters. They were basically 21 millimeters. They then fracked the balloon. They fracked the valve, meaning put a more rigid balloon in, blow it up even bigger, and actually crack the bioprosthetic valve. So you don't care about that valve anymore in its frame. It's not going to go anywhere, but you crack it bigger than it was designed to be to allow the sapien to expand even further. So this is fracking, just like in oil and gas. You sort of break rock. That's the analogy. That's the term. And now you see the diameter, measured exactly the same place, is now 23. So you gain 2 millimeters on both sides in both directions. Huge difference. So the gradient went from 6 to 1. That's the gradient effect. So a very important, very acute case, and this is the advantage of an NPR. It'd be hard to do this comparative measurements without doing that. Any questions about that part? Okay. And then the new valve function measured with an X-plane, which is also a version of 3D. You can throw color on there. This is the new valve functioning, valve and valve. Here's the color. Note the frame rate difference. Again, 8 down to 4. So color always costs you frame rate, but really we're just looking for PVL in some spot we had missed before. As long as you've got a few systolic frames, that's sufficient for what you need. Normally we have an EKG. That was a technical challenge in the OR that day. Then as I showed you before, you can add the bubblegum view or the true view, and it's pretty. It doesn't really add any detail that I can figure out yet, but that's a personal preference. And then finally, in this case, you have to make a very large ASD to deliver this valve. That's a big hole. You can get right to left shunt after having done a large iatrogenic defect, and particularly if the balloon expand the septal defect to get a sapien valve in. So often we close it on the way out. And this is very quickly, X-plane 3D application, deploy a septal occluder, ensuring that you've got discs on both sides of the septum.
The fracking does not damage the new valve?
No, because yeah, what happens is important to recognize when you're measuring these, when you have a metallic frame, the more you expand it, the shorter it gets. Because that's a slinky sort of frame, right? The cells are still the cells. So the bigger you go this way, the shorter it gets this way. So you have to be thinking through your depth, and you have to intend to do that, because if you are too shallow to begin with, and you try to frack it, the whole valve gets shorter, and now you get PVL. So that's part of the math, is when you put it in, recognizing it's not foreshortening, it's true shortening. So it's an imaging conference. The difference between foreshortening versus shortening. Foreshortening is an imaging perception, where you look at something at an angle and it appears to be a different depth or a different length than it really is. But when you are expanding a valve, you get true shortening, not foreshortening. Okay. All right. So 3D impact, 3D echo, you need a routine integration. So that's the basic message. You don't ever tag it on the end. We can tell those cases. We get TEs from the community where they do a full 2D evaluation, then they throw a blob on the end and send it to us. Like, we're going to suddenly take the blob and do the magic with it. It doesn't work like that, because typically you've missed stuff. They've missed stuff. They don't have the things we need. You should be asking a specific question and answering it with 3D, and it's got to be integrated. It takes practice and patience. If you never do it, you'll never get better at it. But the software, the probes, the tools are much better now than they were even 5 years ago. So I'd encourage everybody to try it. Okay, so that was the end of the 3D part, because that's kind of the update. But I'll take us into a case for yes, those who care about attendance, which is every fellow. This is the QR code. If you missed, Bill, this is how we're actually getting attendance and presenter feedback. So there'd be one question: is Dr. Little a 5 out of 5? And that's it. That's the only question they get. But that's how I get my feedback. Everybody. So this is what we're trying to do: is incorporate QR codes for a bunch of reasons. Okay. So the next short talk I want to give you is kind of applying this kind of stuff. This is a protocol we're working on, but it's sort of consistent with this message: is how do we incorporate 3D into something intentional? So I'll just quickly show you a guideline we're working on the performance of mitral valve TEER. So I think I've mentioned this before. When you do interventional echo, you have to be thinking about patient selection, device selection, size selection. You're going to guide a bunch of steps. You have to do an evaluation of the device and the cardiac function after you've done whatever it is you're doing. And then you got to look at the outcome. Did it work? Can you do it better next time? How are you and your team going to improve? Mitral valve anatomy, shown here. That's what a TEER device looks like. Arms that hit the ventricular side, grippers that fall from the atrial side. You pinch leaflet and then close the entire thing. You go down the middle where there's no cords, typically, ideally, although sometimes you have to move. So this is a document being written for people who are skilled in TE, but don't necessarily know how to do an MTEER. So that's kind of the audience. You're not learning the basics of TE in this case. You have to have some TE skill set. Basic principles and common steps. We're going to avoid kind of all of the possible complications of how to manage everything. It's but basic principles is really the focus. It's a how-to, lots of figures and light on text. And then really the integration of X-plane, 3D, and that's kind of why I'm showing it to you today. So, even the TE probe, you have to recognize there's lots of spots. And this is from the screening structural guideline that we wrote. Upper esophageal is really aortic stuff. Mid is kind of the workhorse, where we do a lot of the imaging. Deep esophageal, we're not often doing that, but this is very important, particularly in tricuspid imaging. Deep esophageal moves you typically past the left heart structures and lets you see the RV and the tricuspid valve. So when that's our focus these days, and it often is, we use a deep esophageal image. Transgastric, very common, of course, and then the deep transgastric to look back at the aorta. So it just sort of defines the different views of a TE. Lots of examples and integration of 3D, including ICE. I'll talk a little bit about that. So in TEER, there's a lot of patient selection, and we sort of screen these patients all week long. The basic clinical things: symptomatic, severe MR, is it primary or secondary? Have they had GDMT? Have they seen a surgeon? Do they have another surgical option, yes or no? But after all that, then you get into the anatomic stuff, which is where the imaging comes in. So this is one of there's many versions of this, but this is sort of the traffic light approach to these cases. Green, go; red, don't go. The green stuff tends to be also the criteria that were in the Everest study. So the very, the 20 years ago MitraClip, the very first cases with very poor imaging and only one size clip. You had to be very selective on who you could do with any hope of success. But this is, central, no calcium, long leaflets, small gaps, sort of the ideal case. And then just increasingly complicated, all the way to the red ones are heavily stenotic, very small diastolic areas, deep clefts. These ones you generally want to avoid. And then, most of what we do is either complex or very complex. This is the workhorse of the cases that we're getting referred these days, is these two complicated areas. And the 3D is everything. Two fundamental platforms by two different manufacturers that are currently commercially available to us, an Abbott system and an Edwards system. Both similar in that their grasping mechanism, they're still created coaptation zones, so they're both referred to as TEER. We used to call this Procedural MitraClip. That was one device, but now we have two platforms, so we avoid that term. But you have to consider how long are the arms, where they're going to go, how wide are the arms, and that was a discussion we had on a case this morning. We used a long fat clip for the first clip, and then it was a functional case. We had a small gap and a kind of an area getting smaller and smaller. Some concern about creating stenosis, so we used a long skinny clip for the second one. So you have to make these clip determinations based on real-time evaluation of how the case is going. So how do we do these cases? Is baseline evaluation. You have to get access to the LA. You have to guide the catheter and delivery system to the left heart. You got to get across the mitral valve in the right orientation, position the leaflet grasp the actual leaflets, a quick functional evaluation of, so now you actually have coaptation created. What's the chamber doing? What happened to the color? Is there a mean gradient, the pulmonary vein? So you do an evaluation of your function while you're still attached before you release the device. Then you decide to deploy it, hopefully, get the catheter safely out of the left atrium, and then kind of decide what you're going to do with the septum. Do you close it or not close it? And these are sort of the general 9 steps of this case. So step 1, understanding the pathology. And again, I'm showing you this to sort of give you real-world examples of integration of 3D. So we certainly still use a lot of 2D, high frame rate, high resolution, good spatial. The prolapse here, the significant MR. We have the 3D, again with the filters not reduced very much, so it's kind of an overwhelming color. If you just look at that one view, it's hard to tell how bad it is or where it's going, but you can see there's a large color effect. Left upper pulmonary vein, systolic flow reversal, so that's consistent with severe MR. You have to identify the target, so where do we ultimately want to go? You see this prolapsing leaflet. When you've done this enough, you realize this is very medial. It's probably P3. It, in theory, could be A3, but unlikely it could be a commissure, but besides what you would think it's probably P3. But when you look at the 3D, it's very clearly P3, big chunk. Now, it's not P3 in isolation. There's all kinds of pathology all along the posterior leaflet. But the worst functional piece with the eccentrically directed jet is coming from P3. So you have a conversation. This is probably where we're going to drop a clip because you tend to go where the money is. You do a transeptal, again, using X-plane, a function of 3D. You want to be at least 4 centimeters above the plane of the mitral valve. You tent in 2 directions. You make sure you're anterior enough, not too posterior. You make sure you're superior enough, not too inferior. We always do this as well with 3D imaging, looking from the left atrium, so we understand exactly where we're tenting in relation to the fossa ovalis. We added a clock face. The mitral valve's down here, the medial commissure. You generally want to puncture somewhere between 12 and 3. And then you know you're far enough posteriorly away from the aorta, but not too close to the atrial wall. And that's the puncture site as viewed from the RA. So this is all 3D given, 3D facilitated punctures. Then you help them deliver everything to the left atrium. This is the clip, it's open, and you see where it is, but you have to orient them to get a clock face to where they are. So here's the valve. We said it was in this case, it's a P1 prolapse. I think I might have said 3, but it's P1 right here. So we want to deploy a clip over here. Now, as I showed you even on the graphic, there's other stuff over here. So cord free is down the middle. As soon as you get very medial or very lateral, you get into where the cords are, the network of cords near the commissures. So there's new concerns there. These are the commissural cordi, the dense networks. If you get down in there, you can actually get tangled. It can be a disastrous tangle if you spin around and don't know how to undo that. We've had cases where the clip is forced out, it tears several. We've had actually, we have not had, but it has been reported surgical rescue from entanglement in cords. So it can actually be a bad deal to get tangled in there because you don't have any direct visualization unless you open the heart. So this is what you're trying to avoid. This thing that looks like a fish hook, this that looks like weeds, and this sort of outcome. If you get to here, that's a bad day for everybody. So it's very cautious how you orient, how far you go down, using all elements of echo, 2D, 3D, color, X-plane, zooming, you're doing everything to avoid the outcome on the right. One of the features is that the device, at least the Abbott one, has this version of everting. So this is a tool to say, if you go down there and you get tangled, you can't pull up your arrowhead and you can't close blindly on cords. So you evert the whole thing, hoping that you come all the way up and everything slips off. That's a way to hopefully get untangled by everting. The other platform has a different solution to that. It doesn't evert, but it elongates, but effectively creates the same thing. It sort of gets rid of the arrowhead feature so you can hopefully pull up out of the cords and avoid entanglement. But here we are. So again, the 3D elements. So we're positioning. There's this massive black line here, and that is not a tear. It's not a problem. It's the shadow. So we're imaging from the top down, and the catheter gets in the way, and sometimes you can't avoid that because you can't move the esophagus. So you just understand there's a shadow. You can manipulate and move your frame a little bit to try to negate that. Here now we've gotten the right position and we slipped below the valve. Shadow has changed because the catheter position has moved a little bit. And then you take advantage of the differential gain. The device is super bright. It's going to reflect all ultrasound, the open arms of the clip. The tissue is the same as it was a minute ago. So you can turn down the gain, the tissue becomes moth-eaten and basically disappears and reveals the clip for you below in the LV. So you take advantage of the reflectivity of the device and the ability to change gain. And that helps you figure out the orientation of the device now that you're in the LV. This is an example of what it looks like everted with a slight entangle concern. And this is just that other device showing how it can be elongated to sort of get out of that position. And then there's this time where you drop the grippers. So you get deployed, you're positioned under anterior and posterior leaflet. You can see the grippers, the arms dropping here, and then you see leaflet interposed between the arm and the gripper. You want to see the gripper bouncing like that, and we spent a lot of time with slide orientation and coordination and making sure that you've got leaflet grasp. And then you deploy and you do an acute functional evaluation of did you achieve what you wanted to achieve? Do you have to move somewhere else slightly, or do you accept this, be done, accept this, and add another device? These are sort of the conversations. So you're evaluating the grasp. In this case, we've got a good grasp. Here is effectively where we want it to land, but there's still residual prolapsing tissue further lateral. So now it's a conversation of, well, we have significant regurgitation, we have significant prolapse. This is a scenario where we might want to add another clip. On the mitral side, you can generally do this without an issue using just TE, but on the tricuspid side, this is a scenario where we almost always use ICE. So that's a fairly new sort of tool in our quiver. We're using it more and more. ICE, we used it yesterday for a complex tricuspid case. And this is the scenario when you have hardware, when you have, in the case yesterday, there was mitral apparatus, there was a left atrial, there was a atrial septal occluder, there was a pacer lead. Anything else, Issa? I think there was a lot going on there. A lot of other hardware, plus the clip we just put in. So when you're trying to then put another clip beside it, and there's lots of shadows and devices, intracardiac echo can be very helpful in that scenario. The interventional cardiologist actually manipulates the probe. It's a catheter, obviously, but it's a probe. And you use fluoro, and you have a back and forth about the image quality, and you sort of help them, assist them in getting a better image. But this is an example of ICE in the tricuspid valve, and then ICE being used to actually grasp the tissue and leaflet. So rare that we'll use it on the mitral side, but very common now we'll use it on the tricuspid side. But there's an example of that residual tissue. So we're doing that pre-deployment functional evaluation. You can, part of that evaluation is hemodynamics. So baseline, we have S-wave reversal in a pulmonary vein. We have a low LVOT stroke volume from a deep transgastric. Immediately after deployment, we have a resurrection of the S-wave, and we have an improvement in forward stroke volume. So this is sort of the acute evaluation you do. Again, jumping back and forth between 2D and 3D and spectral, you're using everything, all the tools. Just a commentary, the gradient is an important conversation always. We're learning, and this is some of the co-op data, that even a gradient as high as 7 had the same 2-year functional outcome as a gradient of 2. So that gradient in the setting of severe secondary or functional MR is not as important as the reduction of MR is. So I'm not saying to aim for gradients of 7, but should you happen to get a gradient of 7 and a significant MR reduction, at least this data set would suggest that's not a bad outcome. This is a common scenario in echo, and again, where we use 3D. So this is the baseline case, different case. P2 prolapse, very significant. S-wave reversal, pulmonary vein, mean gradient's already 8. So you're like, okay, I'm gonna take this diastolic area, make it smaller. Gradient's gotta go up. Gradient's gonna go over 10. We can't do this. This is excluded, do some other therapy. Except when you realize the gradient is a combination of area and flow. And the idea is if you're gonna have a bigger impact on flow than you do on area, you can actually get away with making the area smaller, provided you made the flow even smaller. So that's this case. So this was clip deployed, S-wave upright. You're not done. You can have an S-wave upright and have a mean gradient of 12. So the S-wave upright is a good sign, but this is the better sign. So now the mean gradient went from 8 to 5. So you decrease the gradient by making the area smaller because you had a very dramatic effect on the flow. And that's why you can put a clip on and not release it. So this is why you're doing a full evaluation while you're still attached. If the gradient after the clip had gone to 10 or 12, you're gonna stop. Yeah, you said.
Let's say you're speaking to this patient, kind of get across the gradient at 8, and you're concerned about that. Is your valve area, if it's, let's say above 4, you're still okay to go? How about if it's less than 4?
That's a very good point. So some of it is how big is the starting area. So if the flow area is 5 and the gradient's 8, then you know that gradient is being driven by the high flow. But if the mean gradient, if the area by 3D planimetry is 3.5, 4, that's on the very small side, and your gradient's 8, now you're worried, because you may not get away with a reduction in flow and a gradient that's reasonable.
So how would you make the decision then if you are going to proceed?
With the case at all, or with the second clip?
I guess
Both.
just with, like, in the example that we were just talking about, like if the valve area is a little smaller, there is somewhat of a gradient, I guess, how do you determine whether to take them?
So it's this calculation. So, flow is directly proportional to the root of the gradient. So increase the flow by 2x, increase the pressure by 4x. So you're looking at it, if it's a very small diastolic area, say 3.5, and it's 3 plus MR, not 5 plus. It's impressive, but not torrential. And there's calcium, and the clips don't come in very small sizes. They come with, they come with regular and large. There really is no mini clip. You're going to be limited. So those are the cases often those patients have no other option, frankly, because they have MAC and the surgeons won't take them, and they're too small for a TTVR or a TMVR. There's no other option. So reality is we'll have a conversation around expectations, and we'll say, we can probably only get one small clip on here. We'll try it, and we've had success with that, but never below 3.5 in my experience. That's the lowest. 3.5 centimeters squared is the smallest we've ever had a success. We've tried less, and then you couldn't deploy the clip. Gradient went to 10. But the other hand, if the diastolic area is 5 and it's torrential MR, we're like, okay, well, we know we can put 1 or 2 clips on that and we'll be okay. So back to this case. So again, 8th, so we've got clip 1, clip 2. We effectively obliterated the lateral orifice. There's no diastolic flow over there. All the flow is on the medial side, and that's okay. So the area is relatively small, but the flow effect was greater than the area reduction, and the diastolic gradient's fine. We've done some work here. This is from a publication we did about how do you quantify the flow afterwards. And in theory, you can take a vena contracta of jet number 1. So there's 2 mitral clips here with there's 2 different jets, and 2 clearly distinct jets, not 2 versions of the same jet, but 2 geographically distinct jets. You can do a vena contracta area on one and a vena contracta area on the other and add them together, and we did a publication on that, but it's technically very hard. It's very hard to do it. Do we do it? No. It's more of a concept. The reality is you clip until you've run out of diastolic area or patience or energy, and that's how you stop. But you also look at pulmonary veins. So here we go. So, again, S wave down, S wave up. Even if the jet looks mild to moderate, if you've had an S wave improvement, we know from some work done here, including a recent publication, that that's enough. So this is one of the first studies that looked at this from the Cedar-Sinai group. Very simply, if the ratio of the S to D was low, so small S wave, this was their cumulative MACE events, and if the S wave was high, so the ratio was high over the D wave, the cumulative events were here. And this is over a year. So the first study that said, okay, it's prognostically important to really change your S wave. And this is from one of our study here just a couple of years ago. Similar, we looked at the 3 important things. Did you reduce the MR by at least 3 grades? On the VTI of the S wave, so from small to big or from negative to positive, if that delta was at least 8 centimeters on the S wave, on the VTI, and if you reduce the LA pressure to at least less than 15. So the more of those 3 things that are independent of each other, the better. And this just shows event-free survival out to 2 years, and the more of these things you achieved, ideally all 3, the greater your event-free survival was. So just more work saying that pulmonary veins matter. So we've put a lot more emphasis recently on that sort of acute functional evaluation rather than trying to add up multiple tiny color jets. And just to beat it to death, another case, P3, 3D showing the P3, very eccentric jet, very hard to see this on a transthoracic. This is the scenario where you've often got a large E wave, a low stroke volume, a normal EF, and you're like, wonder why? Where'd the stroke volume go? Patients don't feel, well, not a lot of color shows up on a transthoracic because it's basically the flow is perpendicular to the angle of insonation, but no S wave at all in the pulmonary vein. Clip here, very off-center, great result, S wave upright. So that's just kind of a quick summary of the new guideline and what's in the works and how we incorporate 3D in real practice. Questions or comments about 3D echo and what's happening today versus what was happening 5 years ago? I would say NPR is a big deal. The probes are much better. We've just got in the hybrid OR and the cath lab a brand new probe and a brand new box, and they're incredible actually. And they can also integrate ICE right into them. So you don't need a separate console for ICE. It all just plugs right in. You can toggle back and forth between the different probes. The color's better, frame rates are better. We have the new TE probe, so it's, well, sorry, the pediatric. They call it pediatric, but really it's for structural. But the probe is smaller, we've seen it. I don't know that we need it for structural, frankly. I'll just tell you that one of the issues with probes and what limits them from getting small, really small, like an ICE catheter, is actually the coolant effect. There's a lot of energy, a lot of heat. So it's actually the radiator function of keeping the tip cold that limits getting them smaller. So one of the challenges on the new structural probe, pediatric probe with 3D, is that it has fewer crystals and the image quality is diminished a bit simply because you can't cool it, because that's part of the compromise of making it smaller. So we haven't used it a whole lot because most esophaguses are just fine for the probe we have, but it is available, particularly in cases with an ET tube or something in the ICU, and you need a little bit of 3D, but not interventional level 3D. That's probably where that will come into play.
Are you using a 3D ICE?
Yeah, the ICE we do, and we do a whole talk on 3D ICE, but we should at some point. We're using ICE more and more now, and it's always 3D. Because you don't use the volume, you can do NPR by ICE, but it's X-plane. The X-plane by ICE is very important. But you're very limited, because an ICE, there's no multi-planar. You can't dial up between 0 and 90 on an ICE catheter. You can rotate the ICE catheter a little bit, but within limits of what you can do. But the ICE catheter is a long rectangle, it's not a square. So you have, whatever it is, 90 crystals in one dimension, only 15 in the other. So if you're looking at 0 degrees, you get a nice image because you're using all 90 crystals. But when you look at 90 degrees, you're using 15 crystals. So it looks terrible. So when you hit X-plane on an ICE catheter, you have beautiful image and crappy image. So the compromise is to go 45-45. So you're kind of going diagonally across the long part of the crystal. It's not truly 45-45, but it's close enough mathematically. And so the X-plane is actually a real compromise compared to a 3D probe that we're used to. But we're learning this stuff, and it's funny how fast the ICs will adopt this. They're like, I want the ICE 45-45. They know quickly, but we are using it. It's a very expensive probe, and so far not reusable. So it's a disposable 3D probe. Don't listen. It's like $3,000 or $4,000 a probe.
Screen.
Yeah. That's, yeah. But the 2D ICE catheter is also expensive, but they can be reused a little bit, like 5 times, but not very long. Okay, well, thank you all.